Hello, everyone. It's my great pleasure to welcome tonight's guest speaker, Professor Anand Saggar. Professor Saggar is here to unravel and elucidate the genetics behind Marfan and Loeys-Dietz syndromes. He is the founder of the International Gene Clinic, and he is a visiting consultant to hospitals in Dublin and Cork. Professor Saggar will speak for approximately 20 minutes, after which he will take questions until 8 p.m. For optimum sound quality, it would be wonderful if you could remain muted until if or when you have a question to ask. And to ask a question, you can simply raise your hand or pop it into the chat feed. And finally, to say that we are recording this webinar, so if you feel shy and would rather not be seen, switch off your video, but everyone's videos are switched off. So welcome, Professor Saggar.
Good evening, and thank you for inviting me. I've just been asked, as you said, to speak for 20 minutes, so this is going to be a little bit of a whistle-stop tour through Marfan's. I appreciate there may be a range of different people, and whom some may know a lot, some may know very little. So it is an overview. I will talk about the genetics and the genes and where I think the gene testing fits in. And the difference is a little bit because I've now retired from the NHS. And I know that Dr. Anjal is on the call. And of course, Anne taught me many things about Marfan's, and I'm indebted to her for that. And I also inherited the clinic that she was doing at St. George's, and then later also at the Brompton. But having left that, I have my own clinic where I see a lot of patients with Marfan's and indeed hypermobility or hypermobile Ehlers-Danlos syndrome, which is probably the most common differential that one's always having to make. So that's where particularly the genetics comes into play. So let me start. I'm going to share my screen and show you some slides. So I was going to start really by saying, of course, we can use pictures, and there are many famous people who've had Marfan's. And of course, there's many patients too are not represented on that slide that have it. And some people who don't quite know whether they have it or don't have it. And as you know, Abraham Lincoln is still thought by many to have it, but others argue that he has MEN2B, which is a related disorder. But photographs help us with these individuals, and they certainly help us too with other patients. And you'll see a picture here of a family, which is clearly this gentleman, which is the second in from the left, has Marfan's, not only because he's so tall against the rest of the individuals, but also because he's got what looks like very, very poor vision with the lenses in the eye. So almost certainly he probably has a lens dislocation. And that's why sometimes wedding photographs are often the best, because they pitch one person against everyone else's height. And so it really is valuable having photographs, particularly in genetics clinics, because they can often give us a diagnosis. And again, genetics is no different to any other condition in genetics. Marfan's is no different to any other condition in genetics, is that we take a history, a family history particularly, and also we examine patients. But in relation to Marfan's, it's very common, about 1 in 5,000 to 1 in 10,000, depending which papers you read and whether you're writing a grant application. And that means there's 12 to 18,000 individuals affected in the UK, which is a huge amount. And 75% familial, 25% sporadic, which means that the 25%, the mutations occurred for the first time, and therefore there won't be a family history because that individual is the first one. And that does happen. We do see that. We call it a dominant condition because we have pairs of genes, and you have to pass down one of the pair, one half of the pair to your children. And that means there's a 50-50 chance that if you have the mutation on one of your genes, copies, that you would pass it down. And autosomal is because it's on the non-sex chromosomes. You might call them the automatic ones. And therefore, it's not, Marfan's will affect boys and girls equally. And of course, we don't have a cure for the condition. All we can really do is to affect the treatment and improve the care. And with the appropriate management, we do now see Marfan's as having Marfan patients as having a normal lifespan. So there's real optimism. There's been some significant advances in the management. I'll mention briefly some of the cardiac management with pairs, this wrap that they have around the aorta. But as many of you will already know, it's a connective tissue disorder due to a gene called fibrillin-1, which was discovered in 1991. And we do find that in people who have a clinical diagnosis of Marfan's in, almost up to 91%, sometimes a bit higher now with new technology. And the cardinal features, of course, are aortic dissection, which is where the aorta, the big blood vessel coming out from the heart, the main root, uh, splits partially or wholly. Lens subluxation, which usually normally only occurs up until the age of 13. A curvature of the spine, we call a scoliosis. A pectus deformity, which is a chest abnormality, either in or out. In is excavatum, like an excavation, and out is carinatum, sometimes what we would call pigeon chest, like a sergeant major in a parade. And then the high palate is very common. It's often described not so much as high because many patients are tall, but it's also said to be vaulted like a roof of a church. And then the palate tends to be a bit narrow, and so the teeth tend to be crowded. And you get this myophonoid, what they call habitus, which is this long, slim face, and sometimes deep set eyes, and occasionally they can be down slanting in the eyes here a little bit. And of course, the other feature many of the patients get, which might lead to them being diagnosed, is they have a spontaneous pneumothorax where the lung bursts on one side, and then of course they present with breathlessness, and that often is a call sign. I'll admit I do get quite a number of referrals from dentists when they find that patients have got a tall and they've got a very high palate, and they usually don't have Marfan's, but it raises concern and anxiety. And now there have been many classifications and ways in which to diagnose Marfan's, but it is still very much reliant upon examining patients. But there is a gene, as I said, and so the criteria have been revised to take into account the increasing technological use of echocardiograms, which can find the stretch of the aorta, which is what happens before it might split or burst, called aortic aneurysm, and also lots of clinical features. And I'll show you what some of those are. And I often get asked, my child or myself, we have all these features. Why don't I have Marfan's? Well, the clinical features are an aid to diagnosis, and you can have your strong suspicions, but officially, with the Ghent nosology, the Ghent criteria, you do have to have a mutation or aortic root dilatation. You can only use the clinical criteria purely if there is someone else in the family who has met the diagnostic criteria independently. And children often don't manifest all of the signs and symptoms, so one has to be cautious when you're examining children, um, and maybe rely more upon finding a gene mutation, or if there's a known gene mutation in the family, identifying whether the child carries that mutation or not, what we call predictive testing. So, as I say, there's a large number of referrals, and only a few do definitely have Marfan syndrome. And of course, if you're concerned about it, one of the things to do, of course, is to refer onwards, looking for the eyes and looking at the heart, in particular, looking at the aortic root. Um, and I think I've already said much of this already, so I won't do that. But some people do obviously come because they've been identified as having Marfan's, and they want to know how they could prevent the gene from being passed down to their children, either by testing once they've conceived, or by doing IVF and selection of the embryo. So there's many different reasons why patients might come. But of course, see, once it's important to make a diagnosis because of the cardiac follow-up, to watch the aortic root, to make sure it's not expanding too quickly, and to intervene when it has expanded and it's enlarged, if indeed it does, and to evaluate, obviously, other family members at risk because of this 50-50 risk, and to give appropriate genetic advice and counseling. But it's important not to overdiagnose. I mean, having this diagnosis can have a lot of psychological impact. Patients can get very worried that their aorta is going to rupture. They obviously have to adapt to some of the things that they're no longer able to do. Certainly, certain sports they're not able to do, things which might strike the chest, like boxing is a very bad idea, or heavy contact sports. Um, insurance implications, obviously, and employment implications. And we don't want to overdiagnose because you'll be making people worry that don't need to worry and using up a lot of resources. So we need to be careful. But if you are diagnosed, clearly sport, travel, social interactions, marriage, fertility decisions, all of these things come into play. And one, remains cognizant and sensitive to those. Uh, so, as I said, if you're diagnosed, you'll get an eye examination as a minimum, and the echocardiogram certainly as a minimum, because that's what you're most worried about. And that's really why I tell the young teenagers when I see them that we can look after them, we can care for them, they shouldn't worry. But the reason we want to see them regularly is because we want to make sure the aortic root is fine, and if it changes, we can do something before it gets to be a problem. But otherwise, they can lead a fairly normal life. So there are obviously other conditions which can mimic Marfan's, what they call the differentials. You can get familial thoracic aneurysms, TAA. You can get contractures in the limbs with these funny crumpled ears overlapping, a bit like that. And we call that Beal syndrome or congenital contractural arachnoid dactyly. As doctors, we use these words so that you don't understand them and we can stay in a job. But it is, we call it Beals. It's a bit easier to say. It's very rare. I've only seen about 4 or 5 cases. And then, of course, the big differential is this thing called Loeys-Dietz syndrome, which used to be called a Marfan 2. And that's it's now considered to be Loeys-Dietz. And there are many different genes that cause Loeys-Dietz, unlike Marfan's, where we've only found the one gene. And Loeys-Dietz doesn't have the lens dislocation, and it can have a cleft palate or even a bifid uvula, the dangly thing at the back of your throat, which is why doctors like to look at that. And that's one of the interesting features. And Loeys-Dietz, unfortunately, I often describe it as Marfan's, but a bit worse because it presents earlier. So it's a big, important differential to be thinking about. And then there's other causes of familial lens dislocation, ectopia lentis, familial scoliosis, curvature of the spine, and even familial pneumothorax. So, quite a lot of interesting things to look at and consider in the differential. And there's another list, which I have. It's interesting. You'll see in that list there's homocystinuria, the second one down. That's a recessive disorder, which means you have to have 2 abnormal copies of the gene. But that is always characterized by a learning disability. So if Marfan's always have normal intelligence. So homocystinuria is a recessive disorder with a different pattern of inheritance. But you do get that Marfanoid habitus, and you can get aortic root dilatation. Bicuspid aortic valves are common, but they're not Marfan's, obviously. But sometimes these patients are referred because if you have a bicuspid aortic valve, which means you have 2 leaves in the aortic valve rather than 3, then the patients will get aortic root dilatation and stretch, and that's possibly related both to the bicuspid aortic valve and some hemodynamic changes. Loeys-Dietz, I mentioned the familial aneurysms. I mentioned Beal's tortuosity syndrome. I've seen a few cases, which is literally where the arteries are very, very wiggly like this, or serpiginous, as we call them, tortuous. And that's another different gene, SLC gene. And then Klinefelters I've seen, which is where men will have an extra X chromosome. And the reason they're referred is because they're tall. They're in the top 20%, and they often have tall stature. And they definitely get referred, and I've had a few of those. And then finally, some women who have epilepsy and are very lax in their joints can have EDS, and they have nodules on their brain, but it affects only females, not males. So if you see someone who has aortic root dilatation, bendiness and stretchiness, and epilepsy, you'll be thinking of a different diagnosis. And Ehlers-Danlos, I put there type 3, as it was called, or hypermobile EDS, is very important to consider because that's probably the biggest differential. And I was speaking earlier before we started, that we definitely see a lot of patients, and that's really one of the reasons why I've been seeing both these conditions a lot, is because the biggest differential is EDS. And there is evidence from a paper by Rodney Graham, the great doyen of hypermobile EDS, that shows that the more bendy and stretchy you are, what they call the Baton score, the measurement of the lever joints, the more bendy you are, the more disproportionate you are in your limbs. And of course, that's one of the hallmarks of Marfan syndrome. And, and so the more Marfan-like you would appear because you're particularly bendy. So I said already we can't apply the criteria strictly in childhood. And we sometimes, we say people don't have it, and sometimes it's wrong because there are a few individuals who do get an aortic dissection. And so there is this worry and balance. And I think that's where gene testing really comes in when people are worried and anxious and concerned. Um, and this is the Ghent criteria, as I said, aortic root, it has to be enlarged with either a lens dislocation or a fibrillar mutation. And you can only use the systemic criteria from examination if you, in the presence of these other features, if you've also got a family history, right, of Marfan's diagnosed using the above criteria at the top there. And here is the criteria, which is quite a nice little box, which is easier to use. I use this in the clinic where you're adding up. And the maximum score you can get is 20 because you obviously the top two, you can't have both. You're going to have one or the other. It's wrist or thumb sign, which is, I didn't put in lots of slides to show you these features, but it's to look at disproportion between the size of the wrist and the length of the fingers. And I think you recognize a lot of those things. Hindfoot deformity, many people ask me, that's really just a more severe movement disorder in the back of the heel that's really quite more severe. And you do see that with this, not just a flat foot or pronation. Um, and dural is the bulging out of the lining of the spinal canal sac, the dura, and that's one of the hallmarks. And you won't see that except unless you do an MRI scan of the spine. And I must say, we rarely ever do that in the NHS when we're looking to try and make a diagnosis. Um, and then the 3 out of 5 facial features there are dolichocephaly, which is this long, thin face, the sunken eyes, the down slanting palpebral fissures, the sort of flatness here in the malar region, we call it, and a receding chin, retrognathia. So, you have to go through this every time and look at them. But as I say, if you just make 7 points on this score, it doesn't make you have a diagnosis of Marfan's. You need to have other criteria, which is where your echo comes in, your eye examination comes in, and your family history. And the Marfan Foundation in the US, of course, has a nice little tool that you can use. I couldn't find this on the Marfan Trust site, but they actually can put this in and you can get a score for yourself. But as I say, this is not diagnostic of Marfan's; it's an indicator. And I think the basic message here from the time I've left is to say that you can't make a firm diagnosis in about a third of referrals. And I think that's where gene testing comes in. And as I said, we find the gene in a high proportion of individuals where we believe the diagnosis is Marfan's. But there, without doubt, we do not find the gene in some individuals. Now that could be because they don't have Marfan's, or they've got one of the other subtypes, or they have Loeys-Dietz, where we find even less genes for some of those individuals. But there are some patients who we are highly suspicious they have aortic root dilatation, and we don't find the diagnosis. Now, whether you want to call it Marfan's or Marfan something else, I don't know, but there are definitely patients with root dilatation. Now, it's important in the bottom box there to look at deletions and duplications because many times I've had patients referred and they've had testing and sequencing looking at the order of the letters, the spelling, but they haven't had missing pieces and extra pieces looked for in the gene, which accounts for about 5%. So you always need to make sure that deletions and duplications have been added in, and it's often an extra add-in test. The NHS does do that, but one needs to do it properly. Now, just to finish off on the gene testing, I'm a great advocate of the gene testing because I think it helps people get clarity, it gives reassurance, and if you have a Marfan look, but you don't have aortic root dilatation and you don't have any lens dislocation, and you have a normal gene test result, you can be very reassured that your residual risk is very small. I mean, we're talking, maybe 2-3% or less even. So really, it can be very reassuring for the future and obviously for the family. Um, in the NHS, they're quite limited about the number of genes they'll do. That's about rationing, and they'll do a panel of genes, but they can be quite short. They won't look at some of the other genes associated with connective tissue disorders. And 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 in the private sector, one does a broader range of genes, but one, I don't want to set one against the other. They're just that the NHS has restrictions as to what you can do. And if somebody puts Marfan's, I've seen that people just get the FBN1 gene. And whereas if they put thoracic aneurysm, aortic aneurysm, aortopathy, which means aorta pathology, they get a much bigger panel looking at other genes as well. So it's always about looking at the test and not assuming that every gene or related gene's been looked at. So I'm now just at 20 minutes. I'll just whiz through the complications. Obviously, I talked about aortic root dilatation, which is very important. And it's this lower part here that dilates most often. And in fact, when it dilates higher up here, that's when you start to think, well, maybe this isn't Marfan's, it's maybe one of the other mimicking conditions. And you can get valvular leaks, such as mitral valve regurgitation and aortic valve regurgitation, particularly when the root gets particularly big and stretched. And here it is the normal size, as you can see. And then as you look at it further on, it gets stretched, and that's what they call the aneurysm. And of course, it can split partially, either just a small amount or a larger part. And you can see that if it splits, it's really very bad news. It's usually fatal. But people have survived. I've seen quite a number, and they're clearly somebody's smiling and looking after them because they've survived a dissection. But you don't want to have an emergency operation. That's why we monitor people. You want to treat people prophylactically, and the results are really good and very safe. And obviously, if people get symptomatic from valvular lesions, that's another reason why you'd want it. And the thing that's missing there is pregnancy. That if it is enlarged, particularly if it's above 4.1, then we would start to think for women that maybe they should have the operation. Because if it gets above 4.5, then there's about a 10% chance that you would get a significant rupture or split of the vessel in the pregnancy. So again, planning, monitoring, getting the right advice at the right time is really, really important. And traditionally, we've always done this root replacement, which is a Dacron graft here, by open heart surgery, splitting open the chest, stilling the heart, having bypass. But lately, there's been a new technology in 2004, which has been basically doing 3D modeling and creating a case that fits around the aorta. You still have to open the chest, but you don't necessarily have to go and bypass, and it wraps literally like that. And this graft effectively becomes rock hard and solid, and it seals itself in and fuses with the aortic root. And so that really stops any splitting happening because it becomes an integral part. You clearly can never remove it. And it's made to measure, as you can see from the left-hand side panel. It's different shapes and sizes for everyone's individual aortic root. So it's made to measure, as they say. And the mortality is very good. The results are fantastic, and I think it's here to stay. And it's really proven itself to be worthy of a new advance for the treatment of patients with Marfan syndrome and aortic root dilatation. We tend to do it a bit early, as you'll see at the bottom. It's really before it gets far too big that you like to do it earlier than later. Um, and these are long-term complications, which many of you will know about, which I've talked about, which is the ocular problems, the skeletal problems. You will see there's high proportion of problems during the lifetime that people will get. And you'll get cataracts sometimes retinal detachment, increased bruising, definitely. Some of them definitely have hypermobility and bendiness and stretchiness, and osteoporosis occurs later in life with a risk of fracturing that occurs. And then treating and stopping the aortic root dilatation is done with tablets, traditionally with beta blockers and also with ACE inhibitors. And lately there's been the use of losartan and angiotensin receptor blocking drugs. And the consensus is that they might be beneficial in Marfan's. They're probably more beneficial in Loeys-Dietz. And they're roughly equivalent to using beta blockers. And so they have an additional benefit. But the important thing is that ARBs and losartan ACE inhibitors are toxic to pregnancy, so you mustn't conceive while you're on those tablets. And you must again plan, discuss with your doctor about the future and what you're going to do. And there are national services. There's clinics at St George's, which I used to attend, the Brompton Hospital. I think the Harefield Clinic now, I'm not sure, is running still as a satellite unit, but it's related to the Brompton. And there's clinics as well at Guy's, the Heart Hospital, and St Thomas's as well now to update that. So there's plenty of cover. Of course, I'm very London centric, but there are clinics elsewhere. Many genetic centres will have them. I know there's a clinic in Southampton. There's definitely a clinic in Manchester. So they're in Newcastle as well. So I'll conclude by saying the diagnosis and management requires a multidisciplinary approach, multi-system effects. It's not just a skeletal problem. It requires people to know about it and to know who the best people are to help with it. I haven't obviously covered every single complication that can occur, but it's important to remember that not all aortic root dilatation is Marfan syndrome. Sometimes we don't find the answer. It's important to have regular follow-up, to have accurate echo measurements, which is why I always suggest people go and see the same unit and the same center. And the importance of family screening is very important because we would start screening children from the age of 10 and certainly monitoring them a bit more closely during puberty, which is when the aortic root can stretch a little bit more quickly. And remember, if you don't put your head in the sand, if you have regular follow-up, we see it as a normal lifespan and an excellent quality of life. So I'm going to stop at that point to allow lots of time for questions.
Thank you very much for concluding on such an uplifting note, and thank you for the brilliantly comprehensive talk. There's lots to digest. I don't know if anyone has a question immediately. If not, if I may ask something, somebody sent a question to our helpline in anticipation of your talk. As a man worried about his son, who has Marfan the external signs and symptoms of Marfan syndrome. He's 14. His echo has revealed everything to be okay, and his ophthalmology appointment is similarly reassuringly okay. But the parents are worried, given his features, that he does have Marfan syndrome and he's being denied genetic testing. And he's only 14. We advise that he return to pediatrics at the age of 18 for an echocardiogram. But in the meantime, is there anything else that you can say or advise on this situation?
Yeah, I mean, there are families that I see because of this and they're concerned. And the NHS does rationing, it does. And it says we're not likely to find anything. And so one is I'm happy, a second opinion sometimes can be reassuring. But one can do gene testing. There are patients, not just for Marfan, but for other conditions that have a gene test because they know that that's 95% likely to find something, and therefore the residual risk with everything else being normal is fine. I think the other thing as well is about managing anxiety and concern and worry is even if that individual was found to have a gene mutation and they had a completely normal symptomatology, completely normal aortic root, and as you said, they're older now, they haven't got lens desiccation, then you wouldn't do anything that would change their management at that moment in time. You would just, you'd say, go away, come back in a year, we'll monitor your heart again. And so I think that you're right. I think the advice you've given them is to say, try and understand that there's very little risk here that this is Marfan's, but come back, review, and if there's any change, then of course one can do gene testing. And in fact, one of the criteria that would create testing immediately is if you have aortic root dilatation, you will get a test. So I can understand why they don't do the testing. And if this is just rationing, you would obviously test everyone if we wanted to provide the reassurance. But the test they're still expensive.
It's true. Thank you very much. Amy has asked if there are any trials in children with Loeys-Dietz syndrome and if it would be a good idea to take part for a 3-year-old.
Well, I don't know the answer. I didn't know that there were any trials ongoing at the present time, and certainly not for a 3-year-old. I mean, remember, you've got to ask yourself, what is it you're trying to stop and prevent? So if it's Loeys-Dietz, the biggest thing you'd be wanting to prevent is aortic root dilatation. And so I would be very surprised if the 3-year-old had that. So you wouldn't be able to measure efficacy in the trial against something. So I think one needs to ask what it is, what the trial is measuring. But there is a clinicaltrials.gov on the website, and they will list trials both here in this country and in the UK and Europe. So you can easily go onto that, and that'll give you a very up-to-date set of what's going on and who's recruiting, what trials are closed, and sometimes even criteria for entry.
That's helpful to know. Pip wants to ask about the Marfan gene testing. I was given a number, 37, as part of my genetic testing results, but I'm not sure what that means and if those numbers are any indicator to the severity of the symptoms.
37, I'm not sure what that is. Maybe it was 37 genes they looked at. I don't know. Um, I'm sorry, you need to be much more
Um,
detailed. 37.
I don't know if Pip can clarify a little bit more, or whether
It was the results. It said something about it was the number of the gene or where on the gene. It was just in the results. I only looked at it the other day and I thought I've got no idea what it means. It was part of my results. And I wondered if you test, do you test where in, because everyone has different, don't they? Do you test where in the gene? And is that different? Can you tell?
Yeah, so that's a very good question, Pip, if I may call you that. It is we used to do what they call hotspots. So if you imagine the gene as being a book and you're trying to find the spelling mistake, you would say, well, we know that most of the mutations are on page 5 and page 10 or 24 or whatever, 67. And you just look for those spelling mistakes on those pages. But now, with what they call the next generation sequencing, they sequence the whole of the gene from beginning to end. So they read the whole book looking for any mistake anywhere along the length. So, yes, is the answer. We can tell where it is. New tech, depending when your test was done, then they would have looked and sequenced the whole of the gene. And this position of the gene and the clinical features is called genotyping and phenotyping, the clinical features. And people are always looking for any correlation between where the mutation is in the position of the gene and what the clinical features might be. And we know a little bit about that in terms of Marfan's, that certain areas can predispose to neonatal early onset Marfan's. We know that some of the some of the mutations, the truncation ones that stop the reading of the protein, can be slightly milder. But by and large, the symptoms tend to run fairly true within families, and the same mutation will obviously run within the same bloodline. So you need to look at your family history.
and a lady called Susan has sent a question in advance. Susan has Marfan syndrome. We've been trying to settle her mind on this question that's really worrying her actually for some time. She has Marfan syndrome. She asks, can Marfan miss a generation? Her sons both got a negative result from the genetic testing, but 3 of her grandchildren show signs of Marfan in their features. I also know someone who has been diagnosed with spontaneous Marfan. Neither parent has any sign of having Marfan, but it's since come to light someone in their family history did have Marfan. Does this person genuinely have a spontaneous mutation, or could it be it was passed down without showing up in their parentage?
So we need to differentiate carefully between symptoms and signs of Marfan's and the gene mutation. So the gene spelling mutation, if we want to call it that, does not miss a generation. It can't. By definition, the genes you have come from your parents. So if your parents don't have a spelling mistake, you can't inherit the spelling mistake. So, but the symptoms certainly can seemingly miss a generation. That can happen. So I can't obviously, you'd have to take each case individually, but if the other person in the family is said to have Marfan's, you'd have to ask yourself, did they truly have Marfan's, or perhaps they were very hypermobile? I've seen plenty of families where there's hypermobility in the family as well as Marfan syndrome, and there's been some confusion. And luckily, those families we found a gene, so we've been able to say, well, you look Marfan's, but you don't have the gene, and this branch of the family does have Marfan's because we've got the gene. So if there's concern and worry, if the person doesn't have the gene mutation and you know what it is in the family and they haven't got it, you can't pass it down. You
This lady definitely, she has Marfan syndrome. She was diagnosed, I think, in her 60s after a dissection, and her sons were genetically proven not to have it. But the
yes.
grandchildren resemble the grandmother, tall and slender. And that's,
So she's got, have they found the mutation in her?
yes,
And the children don't have that mutation.
no.
Right. Well, then, well, you'd have to look at the grandchildren and see why they, what's the criteria for thinking they have Marfan's.
Just their
So,
physical appearance,
yeah, well,
just visually apparent, long legs, long limbs.
well, if there's two children as well, then that wouldn't occur spontaneously in two individuals. So
No.
it, I mean, you'd have to reassess it, I think is the bottom line. But if you're asking me, I suppose the reason I'm hesitating is because, can the Marfan mutation happen again spontaneously in the same family? Well, I suppose it can, but that's like saying, can lightning strike twice in the same place? Well, yes, but it doesn't. And with two children, they're both having it spontaneously again? No, there's something else going on. So they may just be tall children.
Probably. Hopefully so, yes.
Yes.
Thank you.
I'd be very reassuring, but
Alexandra has asked, with mosaic Marfan syndrome, is there a test that can tell you the distribution of the alteration?
you mean in the distribution across the various tissues, I assume is the question. So just for the sake of everyone else, mosaicism is when not every single cell in the body is mutated. So it means you inherit two normal copies of the gene, your cells keep dividing and dividing and dividing, and of course they start differentiating into becoming the outer layer, the middle layer, the inner layer, and then each of those layers subdivides into the blood or the ovaries or the skin. And so somewhere in that, let's say when it's 10 million cells, one of them breaks and mutates, and that Marfan gene is then in those cells that keep on duplicating. So it's a bit like what I call the marble cake, when you've got a bit of chocolate and you stir it a little bit, and then you'll get some chocolate in this place, no chocolate over there, and a little bit of chocolate somewhere else. And that's the distribution of this mutation. So depending on how much you swirl it, how early you put it in the mix, the distribution will be in different places. So it's easy in the blood because it mixes all the time. So when you test the arm, you're testing the whole of the blood circulation effectively. But when you are looking at the rest of the body, you can't. The cells don't move around and mix. So it's like having a tumor on your arm. If you biopsy the tumor, you'll get the tumor. If you biopsy higher up on your shoulder, you won't get it. And because the cells don't mix, there's no way you can tell what the distribution is at any one place. You can take a random guess, but the distribution or the concentration of mosaic cells in any one area is not representative of other areas. But you have to look at the patient. I mean, if they're tall and slim and they've got skeletal features and they've got ectopia lentis and they've got aortic root dilatation, well, then they've obviously got it in quite a number of different tissue layers. And therefore, it's very likely also to be in the gonads, which is where the sperm and the egg come from. So therefore, there'd still be the 50% risk. But you're right, you can't tell. No, the short answer. And you can't biopsy every single cell.
Thank you. And someone has asked, what do twin studies show for Marfan's? Is there a high concordance in the MZ twins and the
Well, if they're monozygotic, they would obviously have the same. Monozygotic means they come from the same egg and the egg is split in half. So they
right?
would both have the same gene. And as I was saying before, there tends to be a degree of what we call concordance, that if it's running with these symptoms in the family, it tends to run reasonably true in the family. But with identical twins, it should be very similar. But with non-identical twins, even though they inherit the same mutated gene from the one parent, the other gene could be the other copy that's not the same. And then remember, you've got other genes generally, which will have an effect on the aortic root integrity and structure. So there's always a bit of variation because you've got the normal copy doing what it's meant to do and correcting things.
Thank you. Then a lady sent me a question. She's long suspected she has Marfan syndrome, just her height, hypermobility.
Hmm.
So she's at the beginning of her diagnostic journey. She's experiencing palpitations and recently spent a night in A&E. She left this morning with a diagnosis of a right bundle branch block and potentially sensory tinnitus.
Hmm.
We've urged she seek an echocardiogram. She was refused one by A&E, but told to return if her pulse exceeds 120. But she wonders, does this right bundle branch block signal Marfan syndrome or?
So per se, it doesn't. I mean, there is an increased incidence of arrhythmias in Marfan patients and what they call Wolff Parkinson White even, which is like a pre-excitation, by the way. Right bundle branch block per se in its own right doesn't usually lead to palpitations. It's quite a common finding we see in people. So I think if she's having palpitations, you have to obviously think about the common things first, like thyroid disease, ischemic, I don't know how old she is, but ischemic heart disease, which is narrowing of the arteries. And if she has Marfan's, obviously you have to put that into the mix as well. So you're right. There's two different things. One is the ECG or a 24-hour ECG where you are monitoring and seeing whether she's having other ectopics at the same time as the other cardiovascular investigations. And an echo, obviously, if there's any concern about Marfan's or structural problems or a thickening of the heart muscle, what they call a cardiomyopathy. So she needs a cardiac review, is a short answer, but they may not do all of that in the outpatients. And if she's settled, then I think it's more about outpatients need review, definitely cardiology, and minimum check the thyroid function.
Thank you. And then there's another young lady's approached us. She's at the beginning of her diagnostic journey. She's sort of collecting these disparate symptoms that she has, and more
Mm.
as they spell Marfan. She has severe pectus carinatum, scoliosis, chronic joint pain since a child, heart palpitations, chronic fatigue. She scars and bruises very easily, eye issues. She has floaters. Her eyes are very sensitive to light. I think she's trying to persuade someone to take her symptoms seriously, and we hope she's being referred for genetics. But in the meantime, we can't diagnose or commit to anything from afar, but she was seeking our thoughts, and I wondered if you could perhaps give advice or your thoughts.
Yeah, well, I would say the first thing that comes to my mind is, assuming there's no family history of sudden death, and I don't know if she's had an echo, if there's no aortic root dilatation.
I think an
Uh,
echo's revealed everything to be okay. She
yeah,
mentioned her parents have heart issues, but hasn't divulged or
yeah.
elaborated.
Well, I would strongly suggest that she may actually have hypermobile EDS, which is where you get joint fatigue, you get joint aches and pains, joint instability, you get fatigue, you get dizziness and palpitations, which are called POTS.
Yep,
And a lot of what she's got sounds like that. So that's the differential I was saying before that many patients come. To complicate things, we know that 20 to 30% of people with hypermobile EDS can get some very mild, non-progressive aortic root stretch. So, she just needs a proper assessment. And the difficulty is, of course, who's going to do that? If the GP or someone refers her as someone who has joint laxity and query hypermobile EDS, they will refuse it.
yep,
If the GP or the referrer sends a letter saying this lady has Marfan syndrome, in my opinion, they will accept it.
exactly. That's right. I think it was suggested she may have EDS, but she's erring on Marfan perhaps to get a referral. But yep,
Well, I'm not
otherwise
going
she's
to say
stuck in
any.
limbo.
I'm not going to say any more because it's being
No,
recorded.
yep. So moving on to the next question. Amy, can you get a wrong negative test? My son has Wolff Parkinson White, pectus excavatum, hypermobility, chronic fatigue, breathlessness, flat feet, and more. His dad Wayne is a patient of yours, has Loeys-Dietz SMAD3.
Oh,
Daughter is also positive, but son negative, and this is confusing. It is confusing.
well, I mean, it would be very unusual in modern day to get a result which was falsely reassuring. But if there's a known mutation in the family and the child has been tested against it, then it would be hard for them to get it wrong. They would normally do things in duplicate. But They can always be technological failures, but I put that risk as being less than 1%. So, yeah, if there's a known mutation, the only issue is you have to relook at the SMAD3 and make sure that that is a genuine bona fide mutation, truly disease causing, pathogenic as we call it,
Yeah.
to make sure that you've got the right gene causing the right problem. And again, I didn't discuss in length because I only had 20 minutes, but when you do any kind of gene testing, every gene is spelt slightly differently to another person. And that's called normal variation because we're not all identical clones of each other. But that normal variation, the laboratory often recognizes and they don't bother to report it. It's when the gene spelling change is truly abnormal, what we call pathogenic or likely pathogenic. It means that we are 90% or more confident that the gene function is disrupted. But below 90% confidence, you can have something called a VUS, a variant of
Yeah.
uncertain significance. And that we're never quite sure. So you'd have to go back to look at the SMAD3 to make sure it was confidently likely pathogenic or pathogenic and not a VUS. Because if it's a VUS, maybe that's not cause and effect. And therefore, whatever the father has, there's been a 50% passing down.
It seems so odd, though, that the daughter has inherited it, and the son, in the meantime, who's older than the daughter, was displaying heart problems and has Wolff Parkinson White. Just
Mm.
incidentally, it was from his.
Yeah. Yeah, they need a reassessment, I think is what I would say. A relook.
Okay, thank you. Does anyone else have questions? Um,
Yes. Sorry. Now, I've got scoliosis and, excuse me, I've basically got no muscle left, so I'm just bendy as anything. I was wondering if that's just muscle, that's possibly Marfan, um, connective tissue disorder.
Yeah, I mean, you don't you don't have aortic root dilatation or any other
Well,
features of
sorry, I'm the lady I'm 51 and I'm the lady who went to A&E
right.
night
Okay.
and they wouldn't give me an echocardiogram even though I did mention Marfan's.
Yeah.
Um,
A&E wouldn't probably do it because they wouldn't have the setup.
no.
Um, but you probably do need to have some testing. Um, yeah, I mean, you were talking about muscle wasting though, were you?
Yeah, because apparently scoliosis one side over the years compensates for the other. So one side sort of
Yes.
stretches and then all goes tight. So now basically I can't keep my back up and I'm doing the core exercises, but it's not helping massively quickly.
Yeah, but that doesn't necessarily. So you just need investigation. You need sorting out. I mean, you obviously got the scoliosis quite significant, and that's
Yeah,
causing you a lot of pain and discomfort.
yeah.
Have you got a? I mean, it depends obviously whether you've got a pectus or a deformed chest in the front as well.
No, I'm a atypical, is that the word? So
Yes.
I'm 6 foot 5,
Wow.
but I don't look Marfan's, but I've got the high palate and I've got the very long fingers
Yeah.
and the very long legs, and arthritis
Yeah.
and hypermobile joints.
Yeah. Well, do you bruise very easily?
No.
Yeah. Well, there are connective tissue disorders that can give you scoliosis and hypermobility.
Mm.
It's called PLOD1. PLOD1 is the gene, and
Ah,
it so that's another. So you'd probably need to be investigated and seen. And if your GP hasn't referred you, probably refer you as having EDS type 7.
thank you very much. The
Have a
important
look
now.
at that. Yes.
Sorry, I'm still not feeling well, so I will be banging on the door of the surgery first thing in the morning and say, please, can you sort me out an
Yes.
echocardiogram
Yes. Yes.
ASAP?
That's right. It's a rare form of EDS that gives you scoliosis and joint laxity, and that probably is what I would be thinking about.
Okay, thank you.
Welcome.
sorry, Alexandra has said that her daughter was diagnosed when she was 2.5, and she was started on losartan due to aortic dilation, and she has had her sublux lenses removed. Can we expect her to be affected at the more severe end in other areas?
I mean, the fact that at 2.5 she's got aortic root dilatation is obviously significant. And with the sublux lenses, she's Marfan, so it would be probably pertinent to know where her gene mutation is. And if it was in the particular area where we know that it affects children much younger, that would be in keeping. But the very fact that she's got the aortic root dilatation at the age of 2.5, she's more severely affected.
I think Alexandra has mosaic Marfan,
All
so
right.
the mother has mosaic.
Mother's got mosaic, yes. So,
Yes,
but
mother,
so
yes,
that
is here.
yes, so the mother's got mosaic. She's probably milder because it's not necessarily everywhere, but it's clearly in her gonads, in her ovaries, because that's what she's now passed down. But because it's in the ovaries, that means it's gone down into the embryo, which means then it's 100%. So the child won't be mosaic because
Right.
she's inherited the mutation. That and it must be it sounds like it's a more severe mutation. Does that
Um,
make does that make sense?
yes, I think Alexandra, you're happy with the answer, I think. Um, just anecdotally from the helpline, I know people say the gene breeds true, but there are so many families, like say with two boys, each has Marfan, and they're affected in quite disparate ways. Is that normal or not?
Yeah, I personally tell people that you cannot predict how severely it would be affected, the child. And I try not to rely upon the past history. And I particularly tell people that if they're planning babies and they want to take the risk without having any pre-selection of the embryo, I say that, all you can be sure about is that the child will have the mutation, but it will not tell you anything really about the severity. And so I'm with you that I think one has to be very cautious not to assume because it's been mild in your family, it'll be mild again. I'm much more cautious.
Yeah, because we have two boys. One's 11 and his brother's 9, and the 11-year-old, he's more severely affected and more obviously Marfan than his sort of
Mm.
smaller brother, but
Yeah,
both have the gene mutation.
yeah, exactly. And that's because all the other genes are playing a part as well as the other gene copy that's normal. Because remember, it's 50-50, is one copy abnormal, one is normal. So it's all about the mix of all the genes put together.
And Stephanie has commented in very layman's terms, my mum told me when I was young, it's kind of like pick and mix, as the way it presents in me and my sister and my father. It's totally different. Yeah,
Yeah, I like that. Pick and
I
mix.
like that. Yeah.
And this is what makes it more difficult, of course. This is a problem, but that's very common in any kind of dominant condition that there's much more variability. When there's recessive conditions where both genes are knocked out, there's no one else to counteract, as it were. So then you tend to be much more severe, much more earlier. Whereas with the dominant genes, there's always that normal copy that's trying to control things.
Thank you. Does anyone else have questions? Um, and Amy has commented, Amy, whose husband saw you, who has SMAD3,
Yes.
she said it wasn't VUS. They've agreed they will retest for other things. So,
There we are. See, I told you I was a proper doctor.
oh, Pip has commented all very helpful. I don't know, Anne, do you have any questions? Dr. Child, our medical director. I don't know.
I had a question, just if you don't mind, like more.
That's fine. Yes, carry on.
Oh, sorry, you were
You've got.
muted.
I'll just speak very quickly
Oh,
and then get out
Yeah.
of the way. Just to say that Pip's number 37 was probably an exon. It's like cars on a train, and this would be number 37 in the train. And we have a map of the fibrilin gene, so where the mutation is affected is located can affect how severe the disease is. Hers is not in a severe region, as far as we know. But if she wanted to have our scientists look at it, she could send us the report of the mutation, and Dr. Jose Aragon Martin could check against the international map and get back to her to try and explain her mutation in exon 37, if that's what the report says. But please send us the whole report. Thank you.
Yeah, well, I think it was that exon. Yes, I think you're right. I'll do that. Thank you.
Yeah. So I'm sorry, Pip, I hadn't appreciated it actually found a mutation. I thought there was, yeah. So and you're quite right. That's almost certainly what it is.
Would you like to ask? Sorry.
FBN gene is, I think it's 66 exons, is it? So 37 will be about halfway through the gene, essentially in the middle of the gene. I had a question just about the sort of the current sort of standard of care testing, and you mentioned it's using sort of NGS methods. Do they sequence typically the introns as well? Do they sequence the coding and the non-coding regions? Because we're
No,
talking
they
about
just the modern technology only goes, the best modern technology only goes about 2 base pairs into the introns usually.
Yeah, because there's been I don't know, a handful of case reports where they've described sort of deep intronic variants that can change splicing. I think they're quite rare, but
Yes.
If I suppose in the future, if full genome sequencing or full FBN sequencing includes the intronic regions, it might be possible to pick up some of these sort of rarer type of variants that can change splicing and potentially can be missed if you're just looking at the coding regions. But I think this is a sort of minority of cases like this. But I mean, there are certainly half a dozen reports of such types of variants.
Yes, you're right, they will. But I think what's more likely to happen is what they call RNA sequencing, which is the template that's taken off the DNA. So if the splicing, which is the way in which the gene is cut up to remove unwanted areas, so it becomes much more shorter, then if the RNA is not made properly or has a mutation in it because of the splicing, then they would pick up effectively the fact that there was a splicing mutation. So I think they're finding more answers because the splicing is wrong, so the RNA molecule is wrong, or even the RNA molecule itself has the mutation in it due to other controlling mechanisms. So that's probably the way forward, and that's what they're doing in a lot of conditions now, making more diagnoses that way.
Thank you.
Thank you so much. Professor Saggar, I know that you're dashing off to a glamorous gala.
My other hat on with the arts.
So thank you for sneaking us in for this amazing hour. Thank you so much, and thank you to everyone who joined us. And if a question occurs to you, by all means, send it to our helpline, info@marfantrust.org, and perhaps Professor Saggar will be kind and answer it. Thank you.
Yeah. No, and thank you very much. I've had a long-standing interest in Marfan's and aortopathy and connective tissue disorders, so I'm delighted to be of help and assistance whenever you need. So thank you for inviting me again.
This was brilliant. Thank you. Thank you, everyone.